A very good morning to all of you and welcome to this Alcon Symposium. We have with us some very esteemed panelists and experienced speakers to share their knowledge with us. Along with me on the panel are Dr. Ramamurthy and Dr. Vaishali Vasavada. And we have two fabulous speakers and looking forward to hearing from both of them. The first talk will be by Dr. Thomas Koenen. I think, again, he needs no introduction. Dr. Thomas is from Germany. He's a renowned phaco surgeon who's done a lot of pioneering work, both with the phaco technology as well with the different intraocular lenses. He also happens to be the Arthur Lim Award recipient this year. So congratulations, and looking forward to your talk in Ahmedabad in August this year. So, and he'll be talking to us this morning on his experience with the PanOptix and Vivity IOL. Dr. Koenen.
Thank you for the nice introduction, for the nice words. It's a pleasure to be here in India. As you can imagine, just arrived in time last evening from Zurich, going through Frankfurt, and you see my affiliation here. I'm chairman at Frankfurt Department of Ophthalmology. You see also my consultant agreements. We consult for many companies, including Alcon, J&J, Zeiss, producers of intraocular lenses, smaller companies in Europe. I would speak today about PanOptix and Vivity at the symposium. See this disclosure here for medical devices manufactured by Alcon. Presbyopia is really kicking in nowadays. You all know this, more than 1.8 billion people are affected worldwide. This is a publication here. And if you look at the publication, you can see that over the next 10 to 20 years worldwide, there's even an increase. And so this is the University of Frankfurt, the main building, and you can see the patient looking at this has presbyopia. You cannot see the chart. Presbyopia in Germany is also increasing. I just put this slide very quickly. We have the red bar actually at the moment, but we expect over the next 20, 30 years even more presbyopic patients. So it's important for us in Germany, and as I already showed, worldwide. A recent global cataract survey confirms the opportunity to enhance access in presbyopia IOL. You can see that there is a pre-op patient of willing to pay 75%, but only 3% approximately receive, for example, a trifocal lens. So there is a huge opportunity, a huge need. You can say however you want, but you can see that there is also everyday activities are what patients look forward to enjoy most post-cataract, and that is more than 3 in 4 agree that they expect to enjoy more day-to-day activities. So that demonstrates basically that there is a need for these reading activities or using electronic devices. We have to address this as physicians. Just the thinking is, in my country, we still have more than 90% monofocal lenses, but there is a need. People they ask me all the time for, can you do something better than a monofocal lens, which my partner, which my neighborhood has? What can I do? So here we put together this slide, which is actually on these two platforms we're talking today, the PanOptix and the Vivity, and you can see that Clarion PanOptix IOL, which we have available now in Europe, in Germany, daily near vision activities, reads frequently, sewing on needlepoint, healthy eye is on this side. On the other side is demand patients' sensitivity to visual disturbances. So in my opinion, somebody who drives at night, is a perfect. And then you have a shared characteristics who difficult to understand sometimes. They can have both in a way. And it's a little bit I think the responsibility of the physician to find that out. It's sometimes not easy. Now here's a chart decision tree for Alcon family. And it starts on the right side with patients basically having no need for, let's say, want to have near visual acuity. What I found in the lower part here, always the differentiation between monofocal and toric lenses. Let me summarize what I do. I don't even ask my patients in presbyopia correcting IOLs for toricity anymore. I just correct it. because if you don't address astigmatism, then the patient is not happy. So for me, it's a question of a monofocal lens, an EDOF lens, or a multifocal lens, and I always address the astigmatism. I think it's just easier. I can go down this line, what patients, I come back to this. If you look at the Clarion Panoptics IOL, you have a range of vision, low visual disturbances for a multifocal lens. Spectacle independence is very strong, and improved contrast sensitivity in compared to previous multifocal lenses. Here is the proprietary enlightening optical technology. Important for you to understand is that the near visual acuity is at 40 centimeters, and usually the intermediate would be at 80 if you take a trifocal, normal trifocal IOL. But because of the quadrifocality of this lens, we have now the intermediate focal point as 60 centimeters compared to 80 centimeters. 60 centimeters is what I see here at my computer screen. I had the pleasure to implant actually the worldwide first IOL in Germany. That was, it's almost 10 years now. It's on the 3rd of July 2015. So in July it will be counting 10 years. We did it with a femtosecond laser technology. You see my team here. There were several publications. I tried to summarize them because we want to have a little discussion at the end. This is a clinical outcome after bilateral implantation of the Panoptics with a huge group of numbers and also with physicians. You can see also from India, from the Netherlands, from Japan, United States, Korea, I think, and from India again. So what did we found? These were 6 prospective clinical studies performed across 56 centers, almost 560 patients, and you can see the outcome here in terms of, or let's say the summary of a US study, an Australian, Belgium, so all over the world, and then also from South America. This was all put together. And what is important is this slide. This shows you the defocus curve. If you see these defocus curve, then you can appreciate this is a defocus curve of a young person between 20 and 30 years, because you see distance, intermediate, and near, and the outcome was a continuous range, and that's important, continuous. When I was doing a lot of bifocal lenses where we had this huge dip for near and for distance, and intermediate you couldn't see, so you were not able to read the computer. Then you can do this with a trifocal. This changed the whole world, in my opinion, in multifocality. And you can see here from very near 33 centimeters to distant 4.4 and 5 millimeter, the peak performance at 66 and 40 centimeters, exactly what we want for these patients. Also, few ocular adverse effects were seen in this study. Not a lot of secondary surgical interventions. Usually that happens if you have a lot of glare, you have a lot of halos, you have a lot of these issues, and people like to complain, and you may have to take out. In my opinion, if I do my selection right, I almost never take out a trifocal lens. Never. It's a rare, super rare indication. I would say 1 out of 1,000 maybe that I have to exchange an IOL. And you can see you can see in the publication, if you're interested, what the outcomes were there. Let me go to this. More than 9 out of 10 patients with this IOL reported never need glasses at all distances. That's a really, really strong, outcome with this finding. 9 out of 10. And you can see here the Panoptics in 13 studies, 513 eyes, 9 out of 10. That's amazing. It's a really good outcome. Low levels of bothersome visual disturbances was also found, and you can see here 97% of the patient reported no highly bothersome visual disturbances, and 95% of the patient reported no severe. Now, what does it mean? If you ask a patient 1 year after trifocal lens, do you have a halo? They always will say yes, because they have it, because otherwise you have no trifocality, and the patient cannot read at 40, at 66. That's the optical principle. We have to understand this, we have to take it away. But the question is, does the patient really bothered by this? If I ask my patients, a year later, you have to ask him for it. They don't come to me and tell me this. You have to ask them. What's important for us in Europe, I think worldwide, in India, maybe in the United States, that we now have the new material. We have it now since actually 2 weeks on all platforms. We have it in the Vivity material. I just started the Vivity the trials were done, but the Clarion material, which is a hydrophobic material, glistening free. You know these thing here. This is a nice paper, which for my colleague, I'm sharing with her the Journal of Cataract and Refractive Surgery. It shows Associate Editor Liliane Werner from Salt Lake City. This is a study on the haze intensity, and they showed that Clarion material is really one of the best materials if you look at hydrophobic lenses. You can see others also there, but the more you go on the right side, the more you have actually these changes in the material itself. So visual acuity at different distances, range of vision, patient satisfaction, spectacle independence, and refractive outcomes was our trial. We did a PanOptix toric trial. Method currently, it was a prospective study at my clinic, single site clinical trial, 3, 6, and 12 months follow-up. 27 patients were included. Interim analysis we can present, and we looked at all these different parameters of visual acuity, the defocus curve, and spectacle independence and satisfaction for the patients. This is a great outcome. Uncorrected, very close in all these areas, far, intermediate 80, 60, and 40 centimeters near, close to 0, 1.0 actually for the near visual acuity, and in the intermediate close to the distance visual acuity. If you correct, you even get it better. That's how it is. You can go from distance and to 80 centimeters, 4 meter, 80 centimeters. This is of course accumulation, and then you have the 60 and the 40 centimeters, showing you in general a very good outcome for these smaller cohort, I have to say, but 27 patients. You still have to examine all of them with the focus curve. This is the focus curve at 3 months post-operative with standard deviation, and very, very, shows the same like we had. This is a previous publication we had done in 2017 with the first series of the PanOptix. And then there is the large study of 550 eyes. I put this in one slide together, and you can see that this really much matches all the 3 studies with this super defocus curve for this lens. We also, 90% of the patient reported spectacle independence. As you can see here, 2 need glasses for intermediate vision. That is low number as we found in our study. Interestingly, our contrast sensitivity in comparison to the Acrosoft PanOptix was a little bit better in this study, so I have the impression that we get better contrast sensitivity with this. We're not approaching a monofocal aspheric lens, which is a previous study we did in Frankfurt as well, but we are very close to it now. Conclusion, as I pointed, good visual acuity, distance, high patient satisfaction, good contrast sensitivity, and 19 patients out of this perceived optical phenomena, but not, they were not bothering by this patient, and they were not concluding about this. So coming back to this selection criteria, because we have not only the multifocal lens, we also have an EDOF lens available, if I'm talking about these 2 platforms. So how do we go this? Let me do this. Extended depth of focus is important. We have EDOF lenses now which are defined by the ISO standard criteria. And I have to speak for Germany and for Europe. There is a burden of IOLs because we have so many intraocular lenses, we don't know which to take sometimes. So we have to follow a little bit the ANSI criteria, and it's a little bit, they are clearly defined for far, for intermediate, for near, what the IOLs should achieve. They should be superior to a control group, negative defocus range at 0.2 logMAR, distance corrected visual acuity at 1 meter, clearly defined what an EDOF lens is. I have the feeling that EDOF lenses are mixed up worldwide. Too many, correlations are done. Vivity, EDOF exceeds the ISO and ANSI standards, which I just summarized, in most of the studies. This is data on file, but of course, Alcon has to register these IOLs, so they have to work in really clear standards, and they have to look at monocular photopic depths of focus, mean monocular photopic, distance corrected intermediate visual acuity at a certain range, then non-inferior to the to a monofocal lens, superior versus monofocal lens in the distance-corrected intermediate visual acuity, and then the distance-corrected visual acuity also. So this has to be fulfilled. A validated questionnaire was used to evaluate the dysphotopsia, which is very important. You can see here, just as an example, no glare and glare, and you can see that the questions were done, the instructions were done, and these are the questions which were taken to the patients. And you see the FDA comment, pro instrument can be used to demonstrate both safety. So it's important to look at this. They were very low in this regard. Now, this comes from a publication we did together, and we looked again at the EDOF. And if I summarize them, you can see that on the right side of this slide, you can see the ISO criteria for non-EDOF lenses. These are the lenses on the right side, starting in the light blue with all monofocal lenses. Then it comes a little bit to indications for presbyo correcting IOLs, but according to the ISO standards, they are not EDOF lenses. They give some presbyopia correction, and we have to clearly tell this to our patient. If you want to be spectacle independent, you have to go into a multifocal lens. If you want to be further spectacle, you go to a real EDOF lens. If you have some intermediate, which is not presbyopia correction, but it's better than monofocal, you go in the middle range, so it's a non-EDOF lens, but works in presbyopia, good for all of us if we have this. Extended depth of focus technology was summarized here. Great paper I think we did together, and there is small aperture, spherical aberration IOL, diffractive and wavefront shaping IOLs. Importantly for me, that you have a non-diffractive lens available. This is the Vivity wavefront shaping technology. I don't want to go into the detail because it extends the depth of focus. And this was also by me studied starting from 2019, where we had the opportunity to do this first in Germany as a first implanter for the Vivity. So that's 6 years ago now. And we published the data in JCRS, Journal of Cataract Refractive Surgery, with our colleagues also. And we found a very nice defocus curve, binocular and monocular. But very importantly, we found a low incidence of halo, 25 compared to 60, 70% with multifocality. So that is the important message we have here. And if you want to achieve a little bit better near visual acuity, we use mini monovision. That's our colleagues from the Netherlands. They have produced this. You slightly aim for the non-dominant eye, half a diopter of myopia, and the dominant eye for emmetropia, and then you can increase the near visual acuity even. We did the same study with colleagues from Italy and found exactly the same, that mini monovision improves our outcome in terms of near visual acuity. Take a look at this slide. This looks at the monofocal lens, a halo profile comparison. I'm interested in this topic. I published a couple of articles on this. Monofocal, Vivity, and then the Clarion Panoptics. This is on the bench, but you can see what the halos are. They are not so much different, much less than I know from the studies. Our defocus curve for the EDOF and the multifocal lens clearly show the difference in near for the multifocality. And if I summarize them, the two papers, I always point out that driving at night is a little bit better with a non-diffractive EDOF than with a multifocal lens. But if you want to read newspaper, then you get a better outcome with a multifocal lens. You have to tell this to your patients. Coming almost to the conclusion, I want to share with you my experience over the last 10 years. I only put here femtosecond laser cases, so all premium IOL cases. And when I look at my monofocal spheric lens, they actually went down. If I look to my monofocal aspheric, which is in green, they went, from basically when we started femto, went up. Most recently, they went up again, and the reason is we started with monofocal plus, but we went down with monofocal plus because I couldn't see so much of a difference in comparison to a good aspheric monofocal lens. We will hear to this later. This is my multifocal data, so huge increase from 2015 when I had the first Panoptics implanted, and then in 2019, as I pointed out, came the Vivity on the market. That's the end of 2024. In March 2025, we very much equal. We have 50% Vivity, 50% multifocal lens. That's my, comes from my clinic, and that's how we treat the patients. Conclusion for me, 1.8 billion people are affected by presbyopia worldwide, and in a recent survey, 75% are willing to pay for a lens, and we know this is a co-payment, usually all around the world, more or less, that is likely to eliminate the need for glasses, but only 3% receive trifocal lens. So there is a lot of opportunities we have. Patients' clinical profile and lifestyle factors are important consideration when recommending the presbyopia correcting IOL. The Clarion Panoptics with the preparatory technology and enlightening technology offers full range of vision. That's important. Near, intermediate, and distance, spectacle independence, low visual disturbances, with the majority of patients not bothered, and improved contrast sensitivity in comparison to the previous models. This is confirmed by worldwide pooled data, not only by our center, it has been all over the world. Latest systematic analysis has been done. And finally, if we look at the non-diffractive EDOF lens with the X-Wave technology, which is a true EDOF lens, exceeds the ISO and ANSI criteria, offering extended vision, including functional near. Functional near means you can read, but if you really want to read the fine print, you need a +1 glass sometimes. But in my opinion, the patients are basically spectacle independence for the whole day. 90%, 95%, they don't need any glasses because they can read the computer, they can drive at night, it's very good. With mini monovision, you can improve this even. Majority patients are no optical phenomena or have no optical, which makes this lens suitable for those sensitive to visual disturbances, and that's my differentiation. So I put this slide together, when do I do multifocal lenses? And you heard 50% there, 50% there. If the patient really wants to be spectacle independent and accepts optical phenomena, I go for the left side. If not, I go for the right side, but I tell them, we can do a little mini monovision to improve near visual acuity, but you need maybe occasionally glasses, which is not the worst in the world, but these are the criteria I use. I thank you for your attention and for the invitation to India. Thank you.
Thank you, Dr. Konen. I think that sets the stage.
Well, just to the audience, just try to get yourself into astigmatic corrections because it's so important. You have to start anywhere. If you don't do it now, just go into it, try anything, go to wet labs, go to seminars. Try to start with simple cases, maybe do first a monofocal toric lens, see how good you are, and then address it, while going maybe to a presbyopia correcting IOL, like we do a lot of Vivity as well, non-diffractive EDOF lenses where you can do it, and it becomes even more important if you go to IOLs like multifocal lenses where you really have to address the refractive error and have to make the patient almost ametropic, and you can only achieve that by, first of all, a superb IOL calculation with the new formulas, AI, the new formulas we have now, and on top of this, addressing astigmatism. That's the way to go. Because I also know that many cataract surgeons do not have a good access to eczema surgery, and then they have to leave the patients, and that's maybe one hurdle, that they don't have that, so they have to address, and it's my prediction would be that we go toric, everywhere as we could in 10 years from now.
So thank you, Dr. Konen. I think we will take the questions towards the end of the session after we heard Dr. Tanya as well. So we are pleased to have Dr. Tanya Trin with us from Australia. She's an exemplary cataract and refractive surgeon, and she has a lot of experience with the education as well. She's also on the RANSCO executive board and is a researcher and has published widely. So looking forward to hearing from Dr. Trin on her experience with the Clarion IOL and how she feels it compares with the iHands.
Thank you so much. So cutting-edge IOL platforms, and when it comes to elevating visual outcomes and reaching patient satisfaction, I've been given the honor of following Professor Konen talking about our monofocal and monofocal toric platforms. But what is in these lenses for intermediate vision? And is it possible that we're leaving something on the table by not considering the intermediate capabilities of these lenses? How far can we push them? And I think that this is particularly meaningful for those practices where there is a price differentiation for the various different types of lenses that you're offering your patients. I am a consultant both in the public and the private system in Australia, and the vast majority of cataract surgery is still burdened in our public system, where we largely only have access to monofocal and monofocal toric lenses. And so being able to push the barriers in terms of the statistics that Professor Conan had placed up on the stage, saying that a vast majority of patients want some sort of presbyopia correction, but only 3% of patients are being able to access these. There is some role to play with when it comes to our monofocal armamentarium. So this is our disclaimer for today. Now, we should have a break just to talk about the Clarion platform, and certainly this is built on the fundamental principles of what has made Alcon lenses so successful since about 1994. And really, we've borrowed from the concepts of the biomechanics and the biooptics, and certainly for the patient experience, it's really been quite a premium outcome, with the Clarion platform then being introduced in 2017, and the intraoperative and postoperative experience for the surgeon itself, and sort of smoother unfolding, not a lot to say in terms of decentration, rotational stability. It really has been a platform that has paved the way for generations of cataract surgeons coming through. Again, you've seen a couple of these slides before. As a cornea surgeon, I like the fact that it is a hydrophobic acrylic, and it has quite a high refractive index for corneal clarity. And again, some of these in vitro studies, if we're going to talk about the elephant in the room, is talking about what is the glistening profile of these lenses. Now, on the Clarion platform, as you can see here in these in vitro studies, the Clarion performs very, very well against its competitors in the same market, and these are demonstrating some of the lowest levels of glistenings in comparison. But not only are we looking at the glistenings, but we're looking also at subsurface surface haze. Again, a very similar study in vitro at the slit lamp. And the Clarion also performs quite well in terms of the haze intensity of what can be seen against its competitors. And the other parts about the lenses that I particularly like is that it's a fully usable optic platform in terms of the 6mm edge-to-edge profile. They have a proprietary edge so that there is less edge glare and dysphotopsia pertaining to that compared to our competitors. And not only were the ND-YAG rates already low on the Acrosoft platform, but they are significantly lower on the Clarion platform thanks to the shape of that edge as well in terms of having a continuous posterior barrier. But what of the Clarion monofocal's function? So what am I supposed to tell my patients if, in Australia we're quite lucky. We don't have a co-payment system, but we do have very generous insurance companies that will pretty much pay for whatever lens I decide that my patient needs to have. But that is certainly not the case in the public system. And I want to be able to tell my patients what is their expected function if I'm only limited to using a monofocal or monofocal toric. Now, we have had the definition of functional vision today in terms of what is the, what do we actually mean when we talk about functional vision? And when we talk about this, we're really looking at that 7.569 vision above the legal limit for driving, certainly in Australia, at about 66. So you're able to read comfortably on electronic devices, and you're able to read slightly larger font at about 66, which is generally a comfortable reading distance, but certainly keeping our small profile, small stature patients in mind as well. So monofocal IOLs might actually have more intermediate vision than we give them credit for. I'm going to go through 3 studies looking at monofocal lenses and what their intermediate capability is. And there is increasing recent interest into the types of lenses that might actually lend themselves to having more intermediate vision correction, and particularly the type of residual astigmatism that may influence the presence of more satisfactory intermediate vision, specifically with oblique astigmatism. Now, the first study that I'd like to highlight is by a colleague of mine, Smita Agarwal. This was a recent publication looking at intermediate vision specifically on the Clarion platform, but pitched as a monofocal IOL in general, and included toric lenses. So this was 63 eyes from 52 patients, assessed at about 3 months after surgery, as well as the first month, using the IOL in a satisfaction questionnaire to assess patient satisfaction, and then using a modified QVID score for binocular visual acuity assessment. They also looked at other biometric factors such as pupil size and postoperative biometry under mesopic conditions. And when we look at this, the post-operative spherical equivalent was pretty much close to plano, 82% of patients within about a half a diopter of the refractive target. And when we looked at post-refractive cylinder, and in this study they were correcting anything above 0.75, average post-operative refractive cylinder was about half a diopter on either side of this as well, about 57% attaining that target. And specifically when we look at these group of patients, about 24% of those with post-operative refractive cylinder had oblique astigmatism, and that's a point that I'll come back to shortly. So most eyes, about over 70%, achieved an uncorrected visual distance visual acuity of about 0 or better, with a distance visual acuity of 0.2 logMAR or better being maintained within about a diopter on either side of defocus. And when we look at the average monocular uncorrected distance visual acuity, it was pretty much close to 0 logMAR, but when we looked at the intermediate, that actually fared quite well as well. So in terms of looking at in uncorrected distance visual acuity, this is obviously better than best corrected in 43% of eyes, but 17% of these were actually found to be two or more logMAR lines worse compared to best corrected. But when we looked at eyes achieving intermediate VA of N6 or better, they were obviously lower than with distance correction, which would make sense given that we're looking at a slightly likely amyopic defocus here. So in terms of pupil size, now this was a small study, so probably not powered at this size, but pupil size and axial length, they didn't find there to be a significant correlation. They specifically looked at that because of one of the other studies that I'll discuss next. When it came to postoperative refraction, there wasn't a significant correlation between uncorrected intermediate and the magnitude of whatever the postoperative cylinder was in this case, but 73% of eyes with postoperative oblique cylinder achieved N6 of uncorrected intermediate visual acuity or better compared to 18% of total eyes. And so there is probably a little bit more digging to be looked at in the space of oblique cylinder being residual. Now, this is a concept afterwards that we've already been leaning on in terms of postoperative uncorrected intermediate visual acuity. It was obviously improved with a myopic spherical equivalent, which is obviously something we've been leaning on over the past few decades. In terms of spectacle independence, binocularity counts. So bilaterally implanted patients did actually have higher spectacle independence for intermediate tasks, in fact, over 50% compared to unilaterally implanted patients. And so that binocular summation also plays a role here. And the slight majority, about 55.3 patients of binocularly pseudophakic patients reported actually not requiring spectacles for any intermediate tasks as far out as 3 months. And they were close to about 1.7 to 1.8 fold more likely to be spectacle independent for both distance and intermediate tasks respectively if they were bilaterally implanted rather than monocularly. Now, we have had a discussion earlier today that there are currently, no ANSI or ISO standards for any enhanced monofocal IOLs. Points about this study is that, the current study really didn't record binocular uncorrected intermediate visual acuity because they wanted to avoid that skew. But when it comes to distance correction and intermediate vision, the addition of distance correction obviously caused a slight reduction in intermediate function, suggesting obviously small amounts of residual myopic refractive area might be actually necessary, and of course is a target when we're talking about our monovision or mini monovision targets. In terms of residual astigmatism, as we were stated, oblique astigmatism might actually improve intermediate function more than with the rural astigmatism. And we look at maybe suggesting somewhere between 0.5 to 0.75 might provide better intermediate outcomes without a substantial degradation of overall vision, particularly for distance. And when we talk about spherical aberration now, the Clarion lens in particular does have an asphericity of about -0.2, and with the native virgin cornea having about +0.27, we can expect that the average eye might expect to have about 0.07 residual after implantation. And a study by Noches in 2011 showed that if we are targeting for around about 0.07 to 0.11, that might actually be a nice balance between achieving visual acuity and depth of focus. And in this particular study, there wasn't a statistically significant difference in the average corneal asphericity between those that did get uncorrected intermediate N6 compared to N8 or worse. But once the correction of spherical aberration was by the IOL was taken into account, The N6 group actually did have an average postoperative SA closer to the optimal range as suggested here. So in this study, the take-home points for me were that both the postoperative refractive target, which we've been employing for years, and lens design might actually be underlying mechanisms providing a little bit more intermediate vision than we expect, but mild residual oblique astigmatism might further enhance lens performance. But also, when we think about it, consideration of biometric factors might actually improve intermediate vision in terms of looking at pupil size and axial length. And this is a study by Morgan Micheletti that also came out quite recently to look at any refractive or biometric variables that might actually enable patients to achieve a little bit more. This is obviously with a competitor lens here, but quite a large study, investigator initiated at this prospective study here of 220 eyes with a fairly even spread between genders, looking at all of the demographic, biometric, refractive, and visual acuity data between the two groups. And we look at these, the only significant factor here was that pupil size is relevant. And this also echoes some of the work done by Damien Gattinel's group, looking at the way pupil size will influence the way your intended lens performs. They compared their enhanced group, the patients who were actually able to see a little bit more intermediate vision, and found that 68% of these respondents using these lenses rarely or never experienced any dysphotopsias, compared to 61% in the group that really didn't get a lot of enhancement in terms of their intermediate vision. And the enhanced group actually had a smaller mean pupil size compared to the non-enhanced group in addition to this. Not only did they find this, but the refraction doesn't seem to play a role in the enhancement of intermediate visual acuity with that particular lens, but certainly looking at smaller pupil sizes may actually help inform your counseling of patients or even your patient selection here. The Clarion monofocal toric or non-toric might actually provide excellent distance and functional intermediate for about 2032. And when we look at comparing these two lenses head to head, again, a study by the same author here, both of these lenses are a single-piece hydrophilic foldable monofocal lens with identical optic diameters and length, but a slightly different definition in terms of getting that enhanced monofocal from our competitor here. And this is again an investigator-initiated study, a prospective again at a single-center bilateral implantation of a fair amount of eyes, 620, with bilateral implantation of either Clarion or in the IHANS, with follow-up about 3 months afterwards, but included patients that were not necessarily targeted for ametropia, but also for monovision, although they did check the visual acuities with the best distance correction in place. And when we see this, they achieved about a 2.5 letter or a 0.05 logMAR difference in mean distance corrected intermediate between the Clarion and the IHANS. So not a huge amount of difference between the eyes. All subjects here had corrected distance visual acuity of about 6.9, 6.7.5 or better. And when you look at the binocular distance corrected defocus curves, they are actually very similar between the two groups. Just conscious of time here, but essentially non-inferiority compared between the two groups for distance corrected intermediate, and certainly the mean corrected distance visual acuity was similar for both the Clarion and IHANS. There may be room, there was an exploratory analysis here looking at a quarter of a diopter offset for the Clarion group to see if there was an improved, and demonstrate that there was a mean improved distance corrected intermediate at the cost of a slight decline, marking potentially that there is some benefit here of targeting slight myopia, which echoes a lot of what Professor Conan was saying earlier today. Thank you very much for your time. Thank you.
Thank you, Dr. Trin. Yeah, I think that we've got some wonderful perspectives on how these different IOLs are useful. So yes, you can please ask your question before. Yeah, so the question is what would be the IOL preference for an ophthalmic surgeon who's doing microsurgery? So we'll just hear from the group. Dr. Ramurthy, would you suggest?
I won't mind getting a trifocal lens implanted in my eye, in the sense that I find that the main complaint about that lens is night driving. And as far as, I don't drive the car myself late in the night, so that's not a problem for me. For most of the other activities, if you get your biometry right and if all other parameters are quite right, it functions quite well. And I'd like to get rid of my glasses whenever I get my cataracts done.
I think the enhanced optics down the optical microscope also help as well with improvements in microscope technology. I wouldn't have issues with putting in trifocality, and certainly the technologies are getting better and better. So I wouldn't have a problem with doing that. I think there are actually other aids, that magnification and the improved contrast down the microscope, that I don't think will be a continued issue for the ophthalmic surgeon. Where I do exercise some caution is if I've got a microsurgery surgeon who perhaps uses loops instead, like my plastic surgeons, I will be a little bit more careful or cautious in those types of patients, because they simply do not have the illumination capabilities that we have down the optical microscope. So there are surgeons and there are surgeons.
No, yeah. So I think I echo the sentiments of both panelists here, but it really, I would leave the choice to the ophthalmologist. There are two choices in my opinion. One is the panoptics, the other is the VVT. If you really don't want to take any chances, not only in terms of your surgery, but also in terms of your lifestyle in the time to come, and then VVT would be my choice. And I agree, we have operated ophthalmic active surgeons who have had the panoptics, and they have come and told us that, yeah, we do see some halos, like Professor Conan said, but they don't bother us, and we would recommend other surgeons to have them. But again, it also would depend on the age of the surgeon, because we are seeing a lot of younger cataracts now, and the other overall lifestyle. But I would choose between VVT if it's somebody who wants to really drive or be outdoors, play golf. Otherwise, panoptics is not a bad idea.
Professor Conan?
This is not working. Is it working?
Yeah, it is.
I think it's a very good question, because all of us one day have to answer this question for ourselves, right? Some later, some earlier. So I think with the both IOLs I presented, you cannot do anything wrong. The only difference would be if you would be a person who has maybe 1 or 2, couple years to do surgery, and this is your main focus, then you might want to really see at all distances, so multifocal lens might be, your preferred choice. But if you gradually want to decrease and want to go more to the golf place, then you might change something. For golf, I also recommend a multifocal lens, because he can see at distance intermediate and near. If you have to drive more, if your desire is in the future to go many times at night, then you may go for a non-diffractive EDOF, because you have at least less optical phenomena. What I also do now, at least in a couple of my patients, I do mix and match. I do the multifocal lens in the non-diffractive and the non-diffractive EDOF in the dominant eye, and still potentially could change. So I think the choice is easy, because you will not make yourself unhappy. You will have basically two great choices.
Yeah. That I think sums up. I think most of the panelists seem to agree that any of these lenses could work. So we have had surgeons who are happy with trifocals, with monofocals, with EDOF. So I think it depends on what their lifestyle is and if they have any other comorbidity. And we also heard this option from Professor Conan on using EDOF in one eye and the panoptics. Just going further on that, in which patients would you suggest doing that? Doing an EDOF in the first eye and a panoptics in the second?
Traditionally, I have never been a big friend of mix and match. Okay. I try to be, the same optic in both eyes usually work, because you can see that patients, if you don't test for monovision, then very often, at least in a couple, 20, 30%, if you don't test, they don't like monovision, and then you have to do something different. You have to treat the monovision, so you have to test it. So I usually try to decide either that way or that way, and this usually works very well, as I showed on my last slide. But if the patient is unhappy, or let's say unhappy, not is the wrong word, undecided, then I give him this option, and I tell him, okay, if you are afraid with a multifocal lens to have too many optical disturbances, let's do your non-dominant eye first with a multifocal lens. And if you're not really happy, if you have too many, and we postpone the second eye surgery for another week, 2 weeks, 3 weeks, we are not under pressure. So put it away, and if the patient comes to me 2 weeks and says, Professor Cohn, this is great, I want the same eye, the same lens in the other eye, then we're there. If he says a little bit too much, then I give him the non-diffractive EDOF in the other eye. And the beauty is we have the same material, same coloration, both are blue filtering light, so the patient doesn't see that difference, and that usually works very well.
Yeah, I think that is a great point. I mean, I think it's important to see these patients after the first eye, especially if you're doing a mix and match, or if the patient is a young patient, 35-year-old, or a myope, just to see how they are feeling with the first eye, the IOL, and then plan the second eye. You want to do a little monovision or a different lens or the same lens. That decision, the first eye's outcome can help us with that. I would also like to know, I mean, now we have an increasing population who've had refractive surgery. So I would just like to know again, what would be your choice in patients who come with post-refractive surgery? What would be your choice of IOL? Would you consider a Vivity? And
I am still comfortable with putting trifocal technologies in. I think our formulas are getting much, much better at predicting their refractive outcomes, but they do require a little bit of additional counselling. And I think that the chair time invested is quite yes. But so long as the higher order aberrations are relatively, and that they haven't shifted over time, it's amazing how much subtle post-LASIK ectasia you'll pick up or you will miss if you are not specifically looking for it. So making sure that your practice is equipped with the right modalities to pick that up, because you may find yourself having a very, very different conversation with patients. And so I think, sometimes for the general surgeon, of which we have quite a few in Australia, implanting these lenses, unless you are really astute at looking at these cases, I don't think just sailing into trifocal territory necessarily is a wise option unless you know what you're looking for.
Can
I think the original concept is if you have undergone refractive surgery, laser vision correction, then multifocals or any lenses of that sort is no, because you already have a multifocal cornea and the optics will not work in sync. I think the concepts are gradually changing. Nowadays it's not just, we have to have a very careful look at the history as well as the cornea at this present day. One thing is whether the patient was very happy with the outcome of the primary refractive surgery. If it was and what was the amount of correction that was done. If it was a -8 or a +4 or something, I would never dare to put a multifocal lens, but it's a simple -2, 2.5 diopters. Patient enjoyed excellent visual acuity, quality of vision, as well as quantity of vision till the onset of the cataract. And when in a topography, if you see a sea of green, and if your higher order aberrations tells you that the amount of total higher order aberrations is less than 0.35, coma is not much, it's a well-centered ablation. These are patients, if the patient is really driven, the fact that they initially went for refractive surgery is that they want spectacle independence. These are the patients where we started implanting EDOF lenses earlier, and now we are switching on to panoptics also in carefully selected cases. So you cannot just say that in all LASIK cases or RK cases it's a no, but all LASIK cases I'll do that. But if I just find that everything lines up, cornea is pristine, then why not? And I have had a situation where I put an EDOF lens with a lot of circumsection a couple of years back, telling that this may not suit you, but the patient was very comfortable, but still was not quite happy with the near vision he got. So he insisted on getting a trifocal done in the other eye. And with both eyes put together, he was reasonably comfortable for all distances.
I just wanted to make one point, that when we talk of doing a trifocal, I agree with sir that in some very, very select cases, optically you may be able to get away with it, but the other issue that we do sometimes see, even with the best calculations, is how much you can predict emetropia in these post-refractive surgery eyes. So we have a series of, which we are about to publish in post-LASIK, myopic LASIK eyes, the non-diffractive EDOF, and it gives really good patient satisfaction and outcomes, but yet it's not 100% of the time that we would end up with a plano for even distance. So my only reservation is, apart from the optics, if everything was okay, I still am very, very hesitant in doing a diffractive trifocal, because these are the patients who go for that technology with the understanding that they don't want to depend on glasses. And when I'm not sure of a complete plano outcome, I'm a little hesitant for that.
Just to add to your point, I always tell all these patients that enhancement might be necessary. So a good look at the cornea to make sure there's enough corneal tissue available, just in case you get a less than optimal refractive outcome, which is quite possible, then a touch-up is...
Let me make one point on these post-LASIK eyes. It's a difference between a patient who had previously -1 and -6 or 8 or 10, because you have a highly aberrated cornea in these, particularly if they have been treatments 20 years ago with small optical zone, non-aspheric eczema profiles. So that is number one. So you have to be careful. I would only go for multifocal lenses if I have a higher order aberration below 0.4 and below. Otherwise, I would go with a non-diffractive EDOF. And then the other point is, be aware, and we just submitted that paper, that even with the best calculation in the world, and we use the Kane formula, we use artificial intelligence formulas, we usually achieve 90%, 85, 90% plus minus half a diopter in non-LASIK eyes, non-refractive eyes. However, we only achieve this in 75 to 80% in our post-refractive eyes. And that's the reason why in most of my patients are ending up with a non-diffractive EDOF lens, because it's more forgiving. If you have half a diopter plus minus, the patient is still happy. If you have that with a multifocal lens, I know multifocal lenses who have minus half a diopter with a quarter, or let's say half a diopter of astigmatism. In brackets, please address astigmatism all the time, because patients are unhappy with astigmatism and multifocality. So when you have these with a non-diffractive EDOF after LASIK, then the patient still likes it.
I think all great points. I think it's time for the next session, so I'd like to sincerely thank the speakers and the panelists for sharing their experience. And please stay back in the hall. We have the next session just about to begin right after. Thank you so much.